for the opportunity to present at the BSR. My name is Lama Bakhsh. I'm one of the trainees at Barts Health. So 20 years to diagnose a case of progressive pseudodermatoid dysplasia. So congenital conditions mimicking inflammatory arthropathies are challenging to diagnose, particularly conditions with predominantly musculoskeletal involvement like spondyloepimetaphyseal dysplasia and progressive pseudodermatoid dysplasia can mimic juvenile idiopathic arthritis, rheumatoid arthritis, or inflammatory spondyloarthropathies. So our case is a 29-year-old gentleman who recently migrated to the UK, presented with progressive deforming arthropathies, initially assessed at the age of 7 for left knee pain back home, for which he underwent an unsuccessful surgical correction. There was no history suggestive of any seronegative symptoms. Inflammatory markers remained normal throughout his follow-ups. Negative family history for inflammatory arthritis or consanguinity. 6 years later, he was diagnosed with seronegative rheumatoid arthritis and ankylosing spondylitis by a rheumatology team in Bangladesh and received multiple conventional synthetic DMARDs with no noticeable clinical improvement. He continued to develop progressive deformities in his hands, elbows, and knees, in addition to increasing spinal kyphosis with loss of functionality. Upon assessment in our service, he had reduced height, long hands and feet with relatively short limbs, bony joint swellings, inability to extend his spine, and stretch marks over the knees. X-rays of the pelvis showed bilateral coxavera deformity with total loss of the hip joints bilaterally and lateral osteophyte formation. There was remodeling of both humeral heads with subchondral sclerosis and cyst formation. The sacroiliac joints were normal. Knee X-rays showed bilateral osteochondromatosis in the suprapatellar pouches, severe joint base narrowing, osteopenia, and modeling deformities with no effusions. Rheumatoid factor and anti-CCP were negative, so based on the X-ray findings, hereditary osteochondromatosis was initially suspected. However, a gene test came back positive for PPD. So progressive pseudodermatoid dysplasia is an autosomal recessive condition with a prevalence of 1 per million due to mutations in the CCN6 gene. Diagnosis is by gene testing and treatment is mainly conservative. So in the first picture on the left-hand side, it shows the patient having bilateral camptodactyles, and then in the lateral X-ray of the knee, it shows the osteochondromatosis in the suprapatellar region, the one that was mentioned previously. So in the learning key points, progressive pseudodermatoid dysplasia highlights the significance of hereditary conditions which can mimic inflammatory arthropathies. These conditions should be kept in the differential when diagnosis GIA, and clinical suspicion should arise in the absence of objective evidence of inflammation such as raised inflammatory markers or synovitis. PPD should be suspected in patients who manifest non-inflammatory joint disease with radiological abnormalities of the spine such as GIA and RA. Since GIA and RA typically spare the spine, a major clue to suspect PPD is the progressive shortening of stature. Characteristics X-ray findings include enlarged epiphyses and widened metaphyses in the pediatric age group, and then as they age, generalized osteoporosis and flattening of the vertebrae. Also, femoral and hip joint deformations can be observed. It is vital for rheumatologists to be aware of anchoring bias that may affect their clinical decision-making and be open to revisit presumed diagnoses when appropriate. Thank you.